Dr. Gutman. I am an emergency physician. I'm also the Chief Medical Educator for CAPYER, who is sponsoring this webinar this evening in conjunction with the Taubman Center and the Ivy Plus Pre-Health Society. Just to let you know that CAPYER is an organization for pre-health students to find paid clinical employment during their gap years. So if anyone is interested, they can contact me after the webinar. But I'm going to go ahead and hand it over to Justin Perry, who's going to be moderating the session for us today. So Justin, go for it.
Hello, everyone. It is my pleasure to introduce former White House Coronavirus Response Coordinator, Dr. Deborah Birx. Dr. Birx also served as part of the President's Emergency Plan for AIDS Relief, or PEPFAR, Director of the CDC's Division for Global HIV and AIDS, and Director of the U.S. Military HIV Research Program at the Walter Reed Institute of Research. Dr. Birx also is an accomplished military-trained infectious disease physician and scholar. To start off, I will be asking a series of questions of Dr. Birx. Feel free to submit questions via our Q&A chat function while I'm speaking with Dr. Birx, and my co-panelist, Bob from Stanford Med, will pose these questions after I'm done speaking with Dr. Birx. In the second part of the event, we will also offer an opportunity for you to raise your hand, and your audio and video will be unmuted for you to ask questions. Please keep all questions respectful and pertinent to our discussion. So without further ado, I guess we will get started at the beginning. What got you interested in medicine and infectious disease? And how did your interest kind of change and grow over time?
Wow, what a great question, because that takes me back to decisions that you all have made over the years. I was actually a math and PChem major, physical chemistry major, and my job offer was from Kodak in Rochester, New York, to work on how to stabilize the green dyes so that in your printed photos, your grass would not turn yellow in the first decade of your photos. That did not seem like an inspirational job to me. And so I applied to, although I was a PChem major, I took biology over the summer and then applied to medical school because I really felt like medicine at that time was really coming into its own with understanding the intricacies of the immune system and those feedbacks. And I just loved KD and math and figuring out on and off rates for different mediators. We didn't know all of them at that time. We had just figured out that leukemia was not null cell, that it was actually a B cell leukemia. So it was actually it was a great molecular time. It was a great understanding of how our bodies work. And it was just an exciting time to go into medicine.
So to that point, how did you start to pursue opportunities within the public health and public service space? And how did that relate to your beginning your career in military medicine?
What a great question. I think this current generation puts much more thought into these things. I just want to say that. I was cooking along, doing really high-level research in the immune system, was working on the immune system when HIV came to be HIV. Before we knew it was HIV, I had been already working on this secondary immunodeficiency for almost 2 years. Again, I was fascinated by how our immune cells talk to one another, particularly when it's responding to an invasion. And so I was doing work and then became a leader. I don't know why. I was one of the few women in the military. At that time, the military wasn't very accepting to women in its ranks. But for some reason, they, A, put up with me, and 2, put me in leadership positions. And I was running the whole program when we were conducting a large 16,000 person trial that I started in Thailand, looking at HIV preventive vaccines, and was worried about the next study that I knew was going to have to be done, further showing how these vaccines could work on different subtypes of HIV. Was exploring sites in Africa in 1998. So I was working in Africa, and Africa in 1998, before Global Fund, before PEPFAR, was a sea of death and despair. I had really never seen or experienced anything like that. In the US, my patients were all on that effective cocktail that was discovered by 1996. And so my patients with 2 and 3 T cells that made it to 1996 were still alive and doing well. And yet I was doing very expensive research in Africa, particularly East Africa, and the communities that I was working and doing the research were dying at a horrendous rate. And so I came back to the US and I said, this is unacceptable. We have to figure out a way to treat the community. At that time, only the individual involved in the research was allowed to get treatment if they seroconverted on a trial. I just thought that was outrageous because there's a great sense of community in Africa, and I knew what would happen. If it went to a mother, she would be splitting the pills with their infected children. And on Mondays, she would take it. On Tuesday, her husband would take it, and she'd be splitting the pills. But no one was going to get effective treatment. And even though I was a researcher, when PEPFAR was announced in 2003 by President Bush, I flew home from Africa and I just said, we have to be part of PEPFAR because we have to bring effective treatment to the areas where we're doing research, because I felt it was morally reprehensible to continue to do research when so many people were dying. So I became part of PEPFAR, and because we were a big research group, we excelled at PEPFAR, which was getting people on treatment because we knew who they were and where they were, and we already had trust in the communities. And so we had some of the largest cohorts of people on treatment within that first 6 to 9 months. And then I got recruited to go to the CDC and then recruited to go to the State Department and run the whole program. But it was not my vision to do that. I was just trying to bring life-saving treatment to communities. And it ended up, some people would say, derailing my 20-year research career and making me much more into a program director.
Switching gears toward our current students on the call, what advice do you wish you would have been given as an undergraduate or medical student? And what advice would you have for our students if they are interested in exploring opportunities for public health and public service at some point throughout their career?
I think 2 things. My number one thing is understand the relationship between mental health and immune function, and mental health and your body's response to all kinds of different assaults. It was not well taught or explored in my medical school. I do believe now that we really understand the intricacies of mediators and how they have to work together and the impact of high cortisol levels on that function of the immune system. I think coming out of medical school now, I think there's a real need to understand that those relationships between how we feel and how we can respond to infectious disease assaults and to any other chronic medical problem. That was just not done when I was in school. And I think there's going to be a lot of pressure to young doctors to really understand and deal with this. And so I wish I had, the brain was like the deepest, darkest ocean. And I mean, it was not understood even at the level that it's understood today. I think there's still a lot more work to do. I think, we default to unclear therapies because we don't understand how all the brain talks to each other and how it really works in a systematic way. And I think we will over the next decade. I think you're going to be the decade of understanding the brain and its impact on how we heal and how we react to disease. And I think you're going to be at the forefront of that, and that's going to be critically important. I think my other advice that I sort of did, now it did get me in trouble. So, don't take this as good advice, but I always led with passion and compassion, and I would go places where I thought I could make a difference. And I put my nose in places that it didn't belong just because I couldn't stand to see that level of human suffering. And so that's how I ended up in a program rather than doing research. And that's how I ended up, frankly, in the White House. I'm not sure that that's a good idea because it did terminate my federal career, although it was probably time that it did. I wasn't specifically trying to terminate my federal career, but I knew that my year in the White House would be a terminal event. And so I still made the choice because I thought I could make a difference, mostly because no one in the United States really understood how to work at the ground level in a pandemic. And that's what I had done for 20 years, whether it was TB or HIV or malaria or Ebola or Zika. That's what I had done. And you cannot control a pandemic from your computer. And I think the United States felt you could. And it really was evident that none of the high-income countries really understood what it takes and what kind of work it needs to be when you're working with communities and you're talking about behavioral change. And I will tell you, no matter what we're confronted with, the first response to any assault often is behavioral change. And so we did that with HIV. Long before there were drugs, there were recommendations of decreasing risk. And I think we just, a lot of misinformation during HIV in those early years. So misinformation is predictable. Everybody in the US acted like they were shocked. Oh my God, how can we have misinformation about COVID? I was like, do you remember HIV? Because we had a lot of misinformation and a lot of cures and all kinds of stuff. And so that's only 40 years later, and we're reliving all of those lessons that we should have learned with HIV all over again. So I think it's going to be incumbent on you all to really force high-income countries to really understand how to really confront pandemics, because what has been done since is not going to put us in a place to confront the next pandemic.
Shifting gears toward your time in the White House as coronavirus response coordinator, knowing what you know now, what would you have done differently in that role starting on day one? And is there anything you would have liked to have told the public that you couldn't due to perhaps political constraints at the time that you were serving?
Well, you're absolutely right. I mean, what I knew from working with presidents and prime ministers around the globe and having them do policies that they don't want to do. I mean, there is nothing better example than LGBT issues in sub-Saharan Africa and what we had to confront to get the ability to have the policies and the access and the decreasing barriers to deliver care. So I knew what I was getting into. I mean, like every other American, I've been aware of the news for the 3 years preceding. I knew what the situation was going to be. I also knew that every other general that had gone into the White House ended up leaving. And so, who had a lot of leadership training like I did. So I knew that this was not going to be a simple situation, but it was a needed situation. And I think what got me to the White House is I cannot stand to watch bad science. And so I was preparing Africa for the onslaught that I could see coming in January. And so I'm meeting with all the African leaders. I'm telling them to use the PEPFAR money. I'm telling them to get ready now because it's going to be very bad. And in the US, we're talking about 10 people. And the thought that you could follow this virus by symptoms. I mean, I was just horrified. So I was writing to the one person I did know in the White House because I had worked with his wife. And I said, look, this is going to be 10 to 20 times SARS, and it's already more distributed than SARS was in the first 3 months within the first 3 weeks. So this is going to be a disaster, and you're not responding adequately. Then the Diamond Princess happened. And to me, that was the penultimate example of asymptomatic spread. They never tested the crew. because they were only testing asymptomatics. Well, you don't have a third of your passengers become infected without a human vehicle that's spreading the virus, and it was the young crew. And so to me, it said young people are not going to get significant illness and older people will. And so you're going to have people running around with virus in communities unknowingly, sort of like the asymptomatic years of HIV, where people didn't know they had HIV. No one was intentionally spreading HIV. They didn't know they had HIV. No one was intentionally spreading COVID. They didn't know they had COVID. And I tell you, when the US started screening people symptomatically coming off of high infectious disease load areas, I was just so horrified that I wrote the White House. And then the next thing I know, they keep calling me, and I said no 10 times or so. And I finally said yes, because I just couldn't stand it anymore. And I think if you lead with passion, that's where you're going to be. You can't be a different person. Now, I have to say, in the first 6 weeks in coming to that White House, the beginning of March, even in that first week, we had a meeting with all of the therapeutic groups, all of the vaccine groups, because I sent them a list of things I want to have in the first week, all of the lab groups. And within 3 weeks, we've had thousands of lab tests rolling out for every single testing vehicle. Why? Because I knew what they were, because those same tests we use for HIV. So I knew the Roche, the Abbott, the Thermo Fisher, and what we needed with Halogen, Hologic, and all of the different groups. And so they all responded. I mean, the private sector brought forth tests in 3 weeks. Imagine if we had done that in January. And what is so frustrating to me, even today, people forget that the first principle of pandemic control is detect. And we're back to, in the United States, symptomatically deciding whether there's community spread or not. And now we're wondering still why in the last year and a half, 350,000 Americans have died. Well, because we're not detecting. So you cannot prevent an infectious disease spread without detection. And I don't know what's wrong with us. We know how to test. We tell people to get tested early for cancer because you find it early, you can treat it early. It's the same with infectious diseases. And just because COVID doesn't poll well, we're back to the same place. So was I disappointed in some of the responses by the Trump administration? Absolutely. Did I fight for other things? Yes. But I can tell you, we got about 80% of what we wanted. As far as therapeutics, vaccines, and tests for the public, and policies at the governor's level. By the middle of 2020, every Southern governor had issued mask mandates, and we're testing. So this whole thing that, Republican governors wouldn't do the right thing, they did. And so did Democratic governors. So we've lost the whole thread of how people work to save communities in this partisan place that we have found ourselves. So the one thing that I did do differently was after the, which often people call the bleach incident, the president was actually talking to a DHS scientist that was behind me. It was a male. And they were in this conversation in the press briefing room, which, as you know, I was looking at the floor going, what is going on? This was for playgrounds. We had the DHS test sunlight against disinfectant because we knew every mom understood how disinfectant worked. And so we wanted to be able to say sunlight can do the same thing as disinfectant to playground equipment. Let your children go outside and play. That was the whole purpose of this, to try to get children back outside and into playgrounds. And it turned into this therapeutic disaster. After that, I made sure that nothing went out into the press that was like that. And so you never saw the Trump administration ever imply that these vaccines could prevent infection, because they weren't studied to prevent infection. They were only studied to prevent severe disease. And yes, they do transiently prevent against infection, but it's so transient. It's not effective enough to create herd immunity. So thank goodness, I learned after that moment, closed doors, beat the science into the room. And that first one was a mistake. I mean, I don't still think, as a military trained person for 29 years, would I have jumped up and screamed at the president? No, but I can tell you by the next day, the president said that he was joking because he knew that what he was saying was not true after the briefing. But in that moment, it was a crisis for me, but it never happened again. And I think that's the best you can do in your life. You can't be perfect all the time. You do make mistakes, but you have to make sure it never happens again.
In that spirit, what were some of the biggest challenges that you faced in your position as COVID coordinator, and how did you work to overcome them? And additionally, how did you shift gears when it became clear that the Trump administration didn't necessarily share your exact vision for a pandemic response?
You never give up. It would have been easy to say, and people say, oh, why didn't you just leave, when things got frustrating? Because you don't. Trained in the military, when you accept a mission, you follow that mission to the end. So you either are removed or someone else removes you. So I was committed once I went into the White House to stay until my job was done or until I was removed. And so I think two things. One, I could never understand the disconnect between what the president was choosing to say and what the president was funding. And what do I mean by that? President Trump would go out and talk about how testing was overrated. At the same time, within hours, he was signing the billions of dollars that I needed to expand testing to every community. So at the time he's saying this, I'm getting the tests that I need to send to the historic Black colleges and universities that didn't have access to PCR and were often in multi-generational households and at high risk. Millions, hundreds of millions of tests went out to individuals who needed them and in situations. So I could never reconcile those two pieces, but frankly, I wasn't going to let it stop me from getting what we need, whether it was Operation Warp Speed, whether it was the monoclonal antibodies that saved hundreds of American lives, literally thousands, to the vaccines, to the tests. I mean, there was this disconnect between the words and the actions that we were being able to do at the federal level. And then they allowed me, by June, I was like, I've got to get out to the states because they're the ones that actually are putting out the policies. The federal government really can't do policy except for the federal workers and for federal institutions. They cannot tell states what to do. And so it's not like Africa and Asia, where you have the public health and clinical care under the Minister of Health, and the Minister of Health puts out the guidance for the entire country. That doesn't happen in the US. The guidance is very fragmented by state. And once that was clear to me, I started going to the states and going over the data by the state level and creating weekly governor's reports that went out every single week from the White House to every single governor, talking about their unique aspects of the pandemic, because it was very regional, and it's still regional to today, on how the outbreaks occur. So sending them their data, my recommendations, and making sure that I was in those states 2 to 3 times per month. And the White House facilitated that, one, by sending out the reports, but secondly, because traveling was difficult, I would be able to fly on the vice president's plane, get off in like Arizona, and then drive from Arizona to New Mexico, across Texas, into Louisiana, Mississippi, and Alabama, over to Florida and back up the East Coast. And it really allowed me to work with community and governors and be very practical. I'm hoping we have some questions from the students.
Yeah, I'm happy to ask a couple of the student questions also. So one of the kind of questions that we have, and in part you had touched on this point early on, but you were kind of fairly involved with the initial phase of the Biden administration's transition out of the Trump administration. And one of the students was kind of wondering, did you ever seek to kind of stay actually as a full-time supporter in the Biden administration, or was it kind of always part of your broader plan to actually leave at the end of the Trump administration? How did you approach that kind of decision-making process?
Well, I was a civil servant, so they could remove me from the White House, but they couldn't really remove me. So, I knew I was radioactive. I mean, there was no way the Biden administration, in the way that they campaigned against the Trump response to COVID, to keep anybody from the Trump COVID response. So everybody was gone within the first 2 or 3 months. But that said, and what the story that's never really told is, starting in August, I was feeding the Biden campaign the same data I was giving to the rest of the country. Why? Because President Biden was an American and he was out in public. And frankly, I was worried, and I was worried they weren't taking adequate precautions, because we had all the data and the governors had all the data and the local public health people had all the data, but I didn't know if they had all the data. And so starting in August, I made sure that I answered any of their questions about what I was seeing relevant to the pandemic. And starting in November and December, every piece of data that I had, they had, because I wanted. Everybody likes to see data in their own way, and that's really important. I think the biggest message is to everyone: learn how the person you're briefing wants to see data, because it has to resonate with them to lead to action. And so I wanted them to make sure that I wanted the Biden administration to understand everything that we were measuring, because not all of it would the White House allow me to make public. In the end, we put it up in December. So all of that data was available in December. And if you still go to the COVID.gov in HHS, you can find all that historic data, which are all the maps and all of the county level data. But I wanted to make sure that they had it, but also I wanted to make sure that between then and January, that we were putting the systems in place so on day one that they could be successful. And so there was a dialogue between their data person and myself and my data person to make sure that all of that was done. And I think that's what America stands for. It doesn't matter who's president. In the end, we support who is elected president, and we support them to make sure that they're successful.
Great. And I just also wanted to emphasize that if any students also want to directly raise their hands, then we are also able to directly call on you to ask. We have one more question, which is basically asking: do you have any specific areas of critique insofar as how the Biden administration handled the rest of the COVID pandemic after the Trump administration?
I can say it because I've sent it to them 1,000 times. I'm not someone who's good at keeping their mouth shut. And so that has come to haunt me throughout my years, but I feel like you have a moral obligation to do that. So my biggest disappointment in the Biden response was twofold. One, taking down testing. I think that testing is integral, and its availability and that data is integral in empowering people to risk mitigate, because we've shifted risk mitigation down to the individual level, and that's fine. Because we do that with HIV, but you've got to give them all the information that they need to make decisions. And that means making testing available, and not just home tests, and not just sending it to the home. We know in the United States where every single person over 65 and every single person on Medicare and Medicaid are. And we have their addresses. And so testing should have gone to those in the greatest need, and that's that population. And not by who could get on the website, who could order tests, but tests should have gone to the people in need. And that's the people on Medicare and the people on Medicaid that were in multi-generational households. Secondly, we should have from the very beginning made it clear that these vaccines, again and again to the American public, that these vaccines were not like childhood vaccines, that these vaccines were only studied to prevent disease. And so unlike childhood vaccines that are built off of natural infection, where natural infection, a single natural infection can live to long-lived protection against reinfection, those childhood vaccines do create herd immunity. They do create long-term protection against significant infection and, of course, also disease. That's not what these vaccines were ever studied to do. And so we should always have been reminding the American people that these vaccines were protection against severe disease and that we were going to study the durability of that because we didn't know how durable they were. And we should have never had that May announcement of 2021 saying you can take your mask off if you've been vaccinated because there is not durable protection against infection. And then we had people unintentionally bring virus back home to their vulnerable family members because they thought they were protected. And so if I have any criticism, it's being crystal clear about what we knew and what we didn't know and not overpromise about vaccines' effectiveness. Yes, it prevents severe disease. Yes, it's important for vulnerable people to get it multiple times, potentially a year, because the South has 2 waves. And the South got no protection this summer because the new vaccine wasn't released until the fall. So we can't just do public health for the Northeast and the northern states. We need to do public health for all of America. And so we really need to ensure that the elderly are immunized more frequently and those more vulnerable. And we need to have layers of protection for the elderly because not every elderly person can respond to a vaccine. Our immune system gets decrepit. I mean, I hate to say this, but with our knees and our teeth and our eyes, our immune system is deteriorating, just like the rest of our body. And so you can't expect an 85-year-old to have the same immune response as a 65-year-old. And so losing monoclonal antibodies was an effective countermeasure for those who don't develop an effective immune response. And we no longer have that because we didn't keep our countermeasures up. And so I do believe that the Biden administration should be working on more durable vaccines that protect people for more than 6 to 12 months, that become much more durable, that can protect both the South and the North because they often have a summer outbreak, to make testing much cheaper and available so that communities know when they're having community spread, because by the time you see new hospitalizations, community spread is already too far gone to protect the vulnerable. And so I think more education about who's truly at risk, how to use these particular vaccines, and real vaccine education that points out the difference between childhood vaccines and the COVID vaccines, because parents now are questioning the efficacy of the childhood vaccines because they know that they've been immunized 3 or 4 times against COVID and they still got infected. So they're trying to understand, is this the way chicken's pox works and our DPT and our MMR. So, I mean, that kind of fundamental education really has to happen at the community level because we've confused people. And so I think clarity is important, transparency is important, and frankly, accountability is important. Yes, the Trump administration could have been much better, but so could our current response be much better. It's not acceptable since 2021, even if you don't start counting to April of 2021 because of that winter surge that began under the Trump administration, you still have nearly 800,000 American lives lost. To me, that's not acceptable. So in our HIV program, we considered every new infection and every death as a failure of our program, so that we could find out why people were dying and put programs in place that prevented it. And so we're not using data today to improve outcomes over time because it shouldn't be acceptable in the 21st century to have people dying from an infectious disease that's preventable if people understood both the disease progression and the disease itself is preventable today.
In that spirit, a lot of our pre-submitted student questions had to deal with what were the major lessons that you learned from the COVID-19 response? And do you think we're ready for future pandemics? If not, what needs to be done from an institutional and policy perspective to help prevent future pandemics? And if we can't prevent them, to mitigate their potential impact?
So we have to look at where we failed, and we failed fundamentally under detect. And we have the capacity now in the 21st century to detect respiratory diseases, all of them, not just flu and RSV and COVID, but parainfluenza, adenovirus. So people know what's circulating in their community, because a lot of those other viruses can cause pretty significant disease in particular age groups. And at this time and this day and age, we should be able to do that on any desktop. You should be able to walk into an urgent care and say, I need a respiratory panel. I have these symptoms. I have vulnerable family members at home. What do I have? And so we're missing out on the fundamental characteristic of a detect, because detect means you have to know what you have so you can identify what is new. And we're not doing that today. We're back to, if you go to the CDC website, we're back to tracking new admissions, and we're tracking influenza-like illness, because we've really degraded all of the testing and testing reporting. So we're not ready for the next pandemic. Now, what I learned from this pandemic was how critical the private sector was. And so the reason we had countermeasures, testing, monoclonal antibodies, vaccines, all within 3, 6, and 9 months was because the private sector dropped everything else and made it happen. And so we know that if they're told this is a problem, help us fix it, that they'll do it. We still have to be able to detect so that we can have the response we need, because we know the private sector performed at an extraordinary high level. I mean, an extraordinary high level. I mean, while everybody else was home, these companies, Abbott, Roche, Thermo Fisher, they brought in all of their employees and they developed those tests within weeks, working 24/7. And so that's what we've learned. Secondly, our vulnerability for essential medicines. Now, I'm used to working in resource-limited settings. I'm not used to the U.S. being a resource-limited setting. And we were a critical resource-limited setting throughout March, April, May, and June for multiple countermeasures, whether it was protective gear, whether it was swabs for tests, whether it was transport media. That's unacceptable in this day and age. We've almost run out of cancer drugs. We've had problems with therapeutics for young children for RSV. We've had trouble with all of this in the last 4 years. We need to wake up and say, this is a national security issue, the fact that we do not manufacture critical essential medicine in this country anymore. And we have to fix it. It's as important as bullets and tanks and weaponry is to be able to tell our citizens that if there's another pandemic, don't worry, we're making cardiovascular drugs, diabetes medicines, vaccines, antibiotics, monoclonals in this country. And we're still incredibly vulnerable. I have seen zero improvement in us protecting us, and you all getting out of there. You are strong. The medical community is strong. It's been under a terrible assault, but they could change policy in Washington, D.C. by saying it is unacceptable in the 21st century in America that we are short of Tylenol or syrups, our chemotherapy. We have to invest in bringing those things home.
I also wanted to call on a few of our students here who have raised their hands.
Thank you, Dr. Birx. This was really, really fascinating to hear about your experiences. And thank you so much as well for all of your transparency. I am especially curious on the points you were just hitting about, the U.S. being a resource limited setting. And one of the things that I think went really well with the COVID response was the vaccine development being a really good example of a successful private-public partnership, which I know the government has been really trying to forward with BARDA and some of these other agencies as well. And my question for you is, how would you want to see the government and the CDC in particular working with private sector organizations to improve other aspects of this public health pipeline, especially you're mentioning the detect portion being the thing that we did wrong? Are there ways that you kind of see the the private sector fitting in there?
I think huge reasons, because there's a lot of motivation in the private sector to also know what's circulating in their communities so they can predict absenteeism. So imagine right now, if in every elementary school and in every congregate setting, we were doing wastewater. It's not that expensive. It doesn't rely on human behavior to come in for testing. You can do the whole profile of what is circulating in the community. I pick elementary schools because, one, they poop a lot in school, and they don't hold it. And they're often asymptomatic individuals when it comes to a lot of infectious diseases, and often are the entry point to the teenagers, the parents, and then to the grandparents. So it gives you 3 weeks of early warning of what's coming that's going to impact your hospitals. And so imagine if the CDC, rather than paying for 1,400 sites, was paying for 50,000 sites, because that's what it's going to take to really understand what's happening both in our rural and urban areas, and to really be able to alert people to local geography. People don't want to know what's happening in New York City if they live in Amarillo, Texas. They want to know what's happening in Amarillo, Texas. They understand that it's not the same. That human infectious diseases require often transmission from other humans. We don't have a lot of animal to human transmission in the United States. We spend a lot of money on that. Let's spend our money on human to human transmission and really have a detection system out there that's transparent and available publicly, and as part of a public-private sector. Private sectors would also support that, because they want to know for their supply chain and their manufacturing, when can they expect high-level absenteeism? So you can see these graphs are very clear. You know that RSV is about a 6-week component in your specific community. It's happening right now in Texas and Florida. It will come to the Northeast probably within the next 4 weeks. But the Texas and Florida are seeing it now. We should have a map right now that shows all the collection facilities and make it available to the American public. I appreciate what BioBot was doing, because you go to the BioBot website, but now they're in a dispute with CDC, and we won't have wastewater probably for a while. But that's why it needs to be a public-private partnership, so we don't have these kind of gaps. These kind of gaps are just completely unacceptable. I think if the government invested in additional manufacturing, even generic manufacturing facilities in the United States, that would be really important. I think, like other things, we may have to pay more. I mean, we're so worried about oil and gas and ability to have our own access to oil and gas so we wouldn't be dependent on others. Yet tomorrow we could run out of a med that if you stopped it, that person would have significant consequences, and we don't have a solution in the US. And so I think we paid attention to oil and gas, we paid attention to DOD, and rightly so, about ammunition, because I came from DOD. But these fundamental things that we need for Americans to thrive and survive, we have not paid attention to when it comes into the health arena.
Great. Thank you so much, Shobha. I wanted to shift back onto kind of an earlier topic that we had briefly touched upon. This is also a student-led question. It's asking, as a pandemic response leader, how exactly did you approach balancing public health needs with individual or societal level feelings? And, especially in the context when there was this need to eventually transition from full school lockdowns into eventually reopening and kind of engaging back in normal life, is there some approach or limit in terms of how you might be able to engage in an effective pandemic response when people are simply refusing to actually follow instructions and messaging more broadly?
Here's my example of that. In traveling the country, I went to 33 universities that opened in August of 2020, because when North Carolina system closed 3 of their major institutions. I think it was North Carolina State, North Carolina Chapel Hill, and NC State, I think. I may have gotten them wrong, or Eastern Carolina. That was 90,000 students untethered from a school living in a community because their parents had rented those apartments and those parents did not want them home. So I didn't want that to happen to any of the other schools. So I went to the largest schools in the United States that were open, which were a lot of them were land grant schools, but some of them were private. And those schools stayed open. And so this stuff that you cannot, people are going to do all this stuff. No, I have an evidence base that 18 to 22-year-olds could be empowered to do the right thing. And often those schools had weekly testing, and the schools that had weekly testing had no community spread. So if you want to know how a response really works, the schools showed us to us. So I think this is an excuse. I think it's an excuse for the fact that Americans are still dying, because it makes people feel more comfortable to say they would have never listened anyway. Well, you know what? You have to try. And I've seen this over and over in pandemics. In Africa, people told me young women would never change their behavior or understand their risk to HIV, and it was impossible. And you just needed to do biomedical because they just wouldn't listen. Not true. We launched a program and their incidence dropped by 50%. People will, with data, and if you spend the time to work with them and talk to them and meet them where they are and answer their questions, not just push it down their throats, not just mandate, but educate, people will change their behavior based on data. But you have to empower them both with the information and the data. So with young women, we showed them these are the most likely partners from which you could become infected. They won't have symptoms. So this is how you're going to have to approach it. And they on their own were able to do that. In the United States, if we did the same thing, community by community, and gave people the data of when they were having an outbreak precisely, not a generic, we're seeing a lot of COVID right now. We're seeing a lot of COVID in the Northern Plains states. This is how it starts. Post-Thanksgiving, there's going to be a lot of COVID because it's the way it starts. And this year in the Northeast, in the Northern Plains Station, RSV, flu, and COVID will come together. But are we educating? Are we saying, no, we're just saying, just get your vaccine? Well, no, let's be really clear. We want you to get your vaccine. You may have elderly individuals within your family who don't have an effective immune response. You may only be transiently protected against infection. You may still bring flu or COVID home. You need to test, give people the tools that they need to be successful. I think in public health, there's a public in public health, and we keep forgetting that. And we aren't willing to sit down and listen to people's concerns and answer their questions. And until we do, we're going to have this divide and this mistrust, because the short way to get what you want is a mandate. But you only do that in a crisis, And you have to tell people this is a crisis and people are going to die, not from COVID, but from other things because our hospitals are overwhelmed. So we have this, we're going to ask you to do this for 3 weeks or 4 weeks, whatever it is. But we have to give people the information, and we're still not giving all the information that they need to be successful despite vaccination. We're not making the additional countermeasures, and we're not preparing America for the next pandemic, but through detection. And this is what gets me, as you can tell, riled up. So if those of you who thought that I was a little bit Pollyannish in the White House, you can tell I am not a Pollyannish woman. The other thing that I forgot to answer is I was shocked by the gender discrimination that existed still in science. And that was shocking to me because I didn't experience that in sub-Saharan Africa for the last 20 years. But when I came back to the US, I would present all of the data on the epidemiology, and then all the press would ask Dr. Fauci the questions. Like I was here's the graph. I don't know where it came from. I made those graphs. So, I analyzed that data. So, this perception that women cannot be scientists, data analysts, understand the math behind the epidemiology is such a fallacy. But the fact that it's 2023 and we're still there is kind of discouraging to me because I didn't experience it in sub-Saharan Africa.
Thank you for that extremely interesting and inspiring answer. I wanted to kind of pass it back now to one of our students, Elon Atlaw, for a question as well.
I had a question about COVID in Africa, given your experience working in sub-Saharan Africa specifically. I just have personal interest in the region, and I was wondering, because of the ongoing debate on how devastating the virus was, especially now that studies are coming out with more analysis of the virus having been more devastating than was reported. Where are you on the debate? What have you been looking at, and what are your thoughts?
Thank you for raising that, because it is interesting with this particular virus. Maybe not with the next pandemic, but with this particular virus, it is particularly deadly, as we know, percentage-wise, to people with comorbidities, particularly obesity and people over 65 that have those comorbidities. So age plus comorbidities is very deadly. Sub-Saharan Africa's median age is between 15 and 16. So as a continent, they have a lot more people who would not be vulnerable to severe disease. And so they probably had as much community spread as we had, but so much asymptomatic disease because of the percentage of their population that's extraordinarily young. And so the death rate, I am sure, for people over 65 was enormous because their ability to have countermeasures, we should have spent, all of us together, in 2021, not only ensuring that people at the highest risk were vaccinated in low and middle income countries, but that the antivirals and monoclonals were available to those who absolutely needed it, because that, in many cases, Africans needed treatment as well as prevention. And so in all of our other programs, whether it's malaria or TB or HIV or Zika, we not only work to prevent disease and get out vaccines, but we work on bringing therapeutics to those in the greatest need. And I think that was very disheartening to me because the work we had done to bring HIV therapeutics. The one thing I really want to highlight, though, is I had spent the last 5 years of PEPFAR, really from 2016 onward, to really work on Indigenous groups taking leadership roles and funding them directly to provide the services, both prevention and treatment services for HIV into the community. And when everybody left Africa, because I could tell you they did, all the Americans came home, all of our international partners came home, and the people on the ground were the local nationals and our Indigenous partners, and they sustained all of the gains in HIV as well as became part of the COVID response. And I just have to highlight that level of dedication. Viral load suppression remained unchanged during COVID. We have about a 94% viral load suppression rate in most of our countries, and it remained unchanged, which meant that patients were getting their medications, which is just remarkable to me. So I just, imagine us if we had that level of viral load suppression and compliance. It would be so amazing. So it's just, sometimes people don't realize that a lot of other cultures are way ahead of us in their ability to provide care because they have such a great sense of community and compassion for others in their community.
Great. Thank you so much again, Dr. Birx. We in our last few minutes here, I just wanted to end on a few of our more forward-looking questions. The first of which being, what are you up to now that you've left the White House, and how much of your work in general now focuses on policymaking and research? And the other question being, what exactly gives you hope and optimism about the future of our healthcare system? We've spent much of our hour here focusing on issue areas and problems, but what are a few of the trends that you've seen that actually give you hope as we push forward into the post-COVID era now?
Well, let's start with hope, because I was very impressed by almost every governor across this country. Governors they didn't know what these PCR things were. They didn't even know where their hospitals were. But I can tell you within weeks, they knew where their hospitals were. They were meeting daily with their hospitals. They were working with hospitals to make sure that people got optimal care. They knew where their labs were. They knew what a PCR test was. And they responded to the crisis, Democrat and Republican. And I think we need to capture that ability. I know that the lesion is not at the state level. So I know the lesion is in our federal institutions. So if our federal institutions got out of Washington and out of Atlanta and embedded themselves in the states. So when you look at CDC should be 75% in the state, supporting the state's response to their major health issues and helping them implement effective programs with using light data in real time. That gives me great hope. It's going to take work. It's going to really take CDC willing to step up to its mission of public health and get out to the states. We've never run a program of global health from Washington, D.C. So we shouldn't be running state level health programs from Atlanta, Georgia. And so we do have work to do there. As I said, I'm a person who, when they see a problem, writes a report or gets engaged and says what I think should be done. I did that about 6 months ago about a company that was making bacteriophage, which could be a great hope for antimicrobial resistance in the future. And so I wrote a report about what needed to be done. And the next thing I know, they called me and they said, go do it. And I went, oh, I don't want to do it. I'm an East Coaster and this is on the West Coast. But here I am sitting in my office in Santa Monica, running the company that called Armada, because in the end, you can't just say it. You can't just say it and expect someone else to do it. You got to do it. And, so I'm still doing it. I am deeply committed to rural health and pointing out the inequities there and tribal nations. There is one group that died at higher rates than any other group, whether you are Black, white, Hispanic, Asian, and that is people who have lived in the rural areas of this country because they do not have access to care. Their issue is not insurance. They do not have access to care. We have degraded completely their care system. And so we have to do research. We have to have NIH commit 15% of their dollars, SAMHSA, where that's 15% of Americans live in rural areas. So let's invest in the research that we need to support them. And the group that suffered the absolute highest fatalities was our tribal nations. And they did because they have paternalistic care being provided often by the Indian Health Service. And we have to tap into their unique culture in order to facilitate both the delivery and acceptance of preventive interventions and care. And we know how to do that. We've done that now for 2 decades in sub-Saharan Africa, and we've dropped the rate of HIV infection down to a controllable level without a vaccine. So I know it's possible, but we as a country have to say that our tribal nations are valuable, that they're part of our community, and we're not going to accept these high rates of fatalities. And the same for those who can't be reached in the cities and for those in the rural areas. We talk about equity and then we don't use data or fund where there is inequity. And so let's stop talking and let's start acting. I'm committed to it. I'm going to stop writing reports, though. It keeps getting me in trouble. That's how I ended up in the White House. That's how I've ended up in California. When I wouldn't let my own daughters go to schools west of the Mississippi, I said, no, I'll pay for any school east of the Mississippi, because both of my brothers went to California and never came home. And so I was not going to accept that. And who is out here in California? Their mom. So, in the end, you have to do what you think is right, and you have to act.
I would like to thank you, Dr. Birx, for taking the time to speak with us. And thank you for everybody who was in attendance. I hope this conversation was informative and that you took home some interesting messages. And with that, big round of applause and thank you to Dr. Birx again.
Thrilled to be with you all. Go out there and change the world. You can. One person can make a huge difference. You're going to be it. So thank you.
Thank you, Dr. Birx.
Thank you, Dr. Birx. Appreciate it.